session. So this session is going to be divided into two parts, one looking at the neovascular AMD part and other in the DME. So this the topic is time for change, integrating faricimab into first-line therapy for neovascular AMD and DME.
Hello, good morning, namaskar. A very warm welcome to the Roche session at APAO. I take this opportunity to invite Brigadier Dr. Sanjay Kumar Mishra, sir, who is the chairperson for this session. Sir's current affiliation is HOD Department of Ophthalmology and Consultant Vitreoretina Services at Army Hospital, Research and Referral, New Delhi. Sir completed his MBBS and MS Ophthal from the prestigious AFMC Pune, followed by which he completed his DNB and long-term VR training from the prestigious All India Institute of Medical Sciences. Sir has been a recipient of several honorable awards, including Param Vishisht Seva Medal, Ati Vishisht Seva Medal, Sena Medal, and Vishisht Seva Medal by the Honorable President of India. Sir also has immense contribution towards academics with 50+ indexed international and national publications, as well as several book chapters to his credit. And sir is an invited faculty at various national and international congresses. With that, a very warm welcome to our session today, Time for Change, integrating faricimab into first-line nAMD and DME. Over to you, sir. A very warm welcome. Thank you so much.
I would also like to invite Professor Dr. Lalit Verma as the moderator of this session. Dr. Lalit Verma needs no introduction. He is currently the director of VR Services Center for Sight with more than 41 years of experience. He is currently the Congress President of this APAO AIOS conference and has been the past president of AIOS, which is the second largest body in the world. He has completed his MBBS and MD from the prestigious AIMS and has been faculty at RP Center. He completed his VR fellowship from USA. He's an avid researcher with more than 170 publications and authored more than 45 chapters in various textbooks of ophthalmology. He has been invited to various prestigious national and international forums for his experience in vitreal surgery and the other research work. With this introduction of my moderator, Professor Lalit Verma, I first invite Dr. Timothy Lai. He is going to speak for Time for Change, integrating faricimab into first-line therapy for AMD. Dr. Timothy Lai is currently coming from Department of Ophthalmology and Visual Sciences at Chinese University of Hong Kong. Professor Lai is honorary clinical professor at Department of Ophthalmology and Visual Science. He is director of Retina and Macula Center at Hong Kong, has published over more than 260 international peer-reviewed papers, and has been awarded with Nakajima Award at APAO and Senior Achievement Award at APAO and the Constable Lecture Award at Asia Pacific VR Society and Senior Achievement Award from APAO. Professor Lai serves on the editorial board of over 10 international ophthalmic journals. His other leadership roles include Vice President of APVRS and Chair of our Global One Advisory Board. Professor Lai clinical research interest lies in medical and surgical management of retinal diseases, particularly PCV, CSR, myopic retinopathy, and CNVM. May I request Professor Lai to give his presentation.
Thank you very much, chairs, and thank you, Roche, for sponsoring this symposium. So in this first part of the symposium, I'm going to talk about neovascular AMD, how faricimab can be introduced as a first-line therapy for treatment of neovascular AMD patients. So these are just some disclaimers. Let's look at the landscape so far. If you look at neovascular AMD, the incidence, it's actually expected to increase a lot in the next 20 years or so because of the aging population. And there's definitely a lot of unmet needs there. So patients frequently need frequent injections. This will lead to patient and caregiver burden. Patients might not go back to follow-up visits, and we therefore get suboptimal long-term outcomes because of insufficient treatment. So faricimab is a bispecific antibody which can target both Ang2 and VEGF-A. So you can see this molecule, one arm of the FAB blocks Ang2, which can stabilize the vessel, reduce vascular leakage, reduce inflammation, and the other portion blocks VEGF-A, which inhibits neovascularization as well as reduce vascular leakage. It also has a modified Fc portion, which can reduce the inflammatory potential. Faricimab has undergone a lot of extensive and ongoing clinical trials. And you can see in DME, we have our Yosemite and Rhine, and then a long-term RONEX study. Neovascular AMD, we have TANA, Lucerne, Avenel X, as well as the PCV sub-study, which is called the CELWIN. In ARIO, we have Barleton and Camino for both branch and central retinal vein occlusion. And we also have myopic CNV, which is currently having the POYANG trial, which is still undergoing. So if you look at the long-term outcome, we actually have more than 1,000 patients in the long-term ALPHA-NEX study, which the results will be reported later this year. If you look at the real-world experience as well, we have very good both Roche-sponsored study as well as independent studies with over 150,000 patients having injected with faricimab. So why is dual inhibition important? So let's go back to the basic pathophysiology of Ang2. So in healthy tissue, you get a low expression of Ang2, and this can actually promote vascular stability in these healthy tissue. But when you get various insults, for example, with oxidative stress, you get an angiogenic switch, and this will increase Ang2, which will displace the Ang1 from the Tie2 receptors, leading to various pathologic states, including leukocyte transmigration, vascular leakage, and upregulation of cytokine, making it more sensitive to VEGF. In the clinical studies, we actually showed multiple biomarkers that dual inhibition is very useful compared with VEGF inhibition alone. So, for example, if you look at the neovascularization and vascular leakage markers, with the use of faricimab, you get greater reduction in fluid and OCT, get greater resolution of intraretinal fluid, as well as greater resolution in PED. In terms of leakage, you also have very good evidence from DMO and ARIO study. You can get better reduction in macular leakage and heart exudates with dual inhibition compared with inhibiting VEGF-A alone. For the Ang2 side, you also get reduced inflammation as shown in the DME study with reduced hyperrefractive foci and also reduced development of ERM in DME cases. Faricimab actually suppresses Ang2, which aflibercept does not. So if you look at the aqueous samples study from the phase 2 trial as well as from TANA, Lucerne, one dose of faricimab, you can actually get absolute reduction in the free Ang2 inside the eye, and this persisted for more than 8 weeks. For aflibercept, you can see there was actually no significant change in the aqueous humor level of Ang2. People might be asking whether we can increase the dose of the anti-VEGF injection to get further improvement in terms of the anatomical outcome. But if you look at the HARBOR and PULSAR study, so HARBOR increased the dose of 0.5 milligrams of ranibizumab to 2 milligrams, and in PULSAR it increased from 2 milligrams to 8 milligrams of aflibercept. But if you look at the mean OCT change, basically these curves overlap each other, so did not show any further improvement. And in the document published by the FDA, when the aflibercept 8 milligrams was approved for neovascular AMD, FDA stated that the study did not establish consistent treatment benefit of high dose of aflibercept in retinal defect drying, and the clinical effect of high dose of aflibercept is questionable. So how does drying achieve, we can achieve the disease control? So if you look at our registration trial, the TANA-Lucerne study, these patients, initially, they would be dosed at a 4-weekly interval for 4 doses. And then if you look at this head-to-head comparison over this time, you can see comparing with aflibercept at this head-to-head level, we can get further reduction in central retinal thickness, as well as a higher proportion of patients with absence of subretinal and intraretinal fluid by about 10% during this head-to-head period. So it showed greater anatomical improvement by having dual inhibition of using faricimab. Another way to look at this is that we can actually achieve faster drying of the macula as well. So this is the Kaplan-Meier survival curve showing the first absence of intraretinal and subretinal fluid with faricimab versus aflibercept. And you can see you can achieve this 75th percentile with the only 2 injections of faricimab compared with a median of 3 injections for aflibercept. So you can get this about 4 weeks earlier. Another very good marker, as you know, PEDs are very difficult to treat, and you can also get very good reduction in the PED height in the head-to-head period. You can see additional 17 microns reduction. So now we have the 8 milligrams of aflibercept available, but unfortunately we do not have a head-to-head study comparing faricimab versus aflibercept. So we can do some direct comparison between faricimab and aflibercept in the TANA-Lucerne study, also a direct comparison between aflibercept 2 and 8 milligrams in the PULSAR study. But how do we do the comparison between faricimab and 8 milligrams of aflibercept? So we can do something called matched adjusted network meta-analysis. So by having this in direct comparison. So if you look at these, they actually handpicked all the matching the subjects in the 2 study, and then they found that by having this comparison, it showed faricimab seems to be able to dry the macula better compared with aflibercept 8 milligrams. So what's the importance of having the drying of the macula earlier? So in the TANA-Lucerne study, it's been shown that if you can get subretinal fluid and intraretinal fluid resolution early within the first 12 weeks, you are much likely to have extended treatment interval later on. So this is more than 80% chance of having the patients in the 16-weekly dosing compared with the 8-weekly dosing. So it is associated with extended durability. In the Farretina and AMD study, based on the AIOS registry, it showed that with the use of faricimab, you can get very rapid improvement in vision, as well as reduction in CST, as well as improvement in vision. And this is actually reflected by a low number of injections as well. And therefore, it showed that the clinical trial data is very well reflected in the real world. Another real-world study is the ChANGe study, also showed that in this patient, they had a substantial reduction in intraretinal fluid and subretinal fluid after being put on faricimab treatment, and the number of injection is also very low. In terms of PED, also 2 real-world studies show that by having faricimab injection, you can get rid of these very difficult-to-treat PED very quickly. Of course, in Asia, PCV is very important, and that's why we performed the SALWIN study, which is a phase 3b/4 study, multi-standard study, including sites here in India, to look at the use of faricimab for PCV patients. So patients, the study design is quite similar to TANA-Lucerne. Patient had initial dosing in the 4 loading doses, and then had disease activity assessment, and then put on either 8, 12, or 16 weekly dosing. But in the second year, it's a bit different. So we can actually have a treat and extend period up to 20 weeks. So this is the only study which allowed up to 20 weekly dosing. So here is the interim analysis at week 16. You can see patients improved by 7.8 letters with faricimab treatment in these PCV cases, and very good reduction in macular thickness. So it's very consistent with what we saw in the ChANGe study. Most remarkably is the absence of subretinal and intraretinal fluid with treatment. So we can achieve 80% at the week 16 mark. And also for those patients with ICGA confirmed polypoidal lesions, 51% complete regression rate was observed, and this is very encouraging because previous monotherapy study using anti-VEGF were not able to show this kind of complete regression rate. So just some take-home messages. So faster drying and greater anatomical improvement with faricimab versus aflibercept has been shown in the ChANGe study. Drying and anatomical improvement data is also reflected in the real world, and rapid drying has led to potential to have extended durability. So now I'll talk about how durability can reduce the treatment burden. So if you look at the patients in the studies, you can see that in the first year, 78% of patients could be dosed every 12 or 16 weekly. And this was actually maintained in the second year. Again, about 78% could be maintained on Q12 weekly or Q16 weekly dosing. If you look at the swim lanes in these individual patients, a lot of patients could actually be put on the Q16 weekly or Q12 weekly dosing without dropping down at all. And for these patients who were always on Q16 weekly dosing, they actually achieved very stable best corrected vision gain and CST reduction throughout the 2 years. You can see they did very well despite just being dosed a few times in the second year. So one of the ways to look at how these patients do in the long term, we can actually, because the ChANGe didn't have allow further extension beyond 16 weekly dosing. So we can potentially look at the criteria if these patients who were already on 16 weekly dosing, if they could actually be potentially further extended. And you can see about 56% of patients could potentially have further extension from 16 week to 20 weekly dosing. In the faricimab AMD trial, basically, we use a disease criteria which is quite reflective of the clinical practice. So you can see these patients in terms of dosing, Q12 weekly dosing or more could be achieved in 78%. But if you look at other criteria, for example, looking at both vision and anatomical criteria, which was actually used in what's in the PULSAR study, they looked at 15 letter loss and CST increase of 250 micron or new macular hemorrhage, then you can see actually this rate durability can be extended in about 96% with the Q12 weekly dosing or more. So definition of active disease in clinical trial is actually quite important. So in the ChANGe trial, we use vision but if you have this hypothetical disease activity criteria using the vision and anatomic, you can get this to 96%. So if you look at aflibercept 8 milligrams trials, Candela, they actually use which is about 53% could get up to Q12 weekly dosing. PULSAR, they use vision and they get up to about 83%. So it's important to look at the extend criteria when you are interpreting these clinical trial data. Looking at the real-world studies, for example, for retina AMD, far-wide AMD, you can see in the second 6 months of the study, very consistent with the real world, with the clinical trial data, only about 2.4 injections. So few injection in the second year show that durability exists in the real world. So you can see real world data reflects the clinical trial data, and based on other independent real world study, both in Morpheus and Japan. Again, over 70% in the Morpheus study could be dosed 8 weekly or less frequent than 8 weekly. And in Japan, again, 67% can be dosed 8 weekly and less frequently. So just take-home message about durability. Faricimab showed that extended durability can be shown in the Lucerne study, and that's also reflected in the real world, which can help our capacity issue in the real world and also reduce the treatment burden of our patients. So finally, just some cases. This case, treatment-naive neovascular AMD, the left eye already and only eye, right eye is poor vision because of a corneal scar, so it's a left-only eye patient. So the patient asked me what treatment should I get. She wanted the best treatment. So treatment-naive patient, so this patient, we offered her having faricimab injection. You can see a lot of shrimp and also PED, so quite a difficult to treat patients if you see this kind of lesion characteristics. So given first dose of faricimab, did very well already, reduction of PED, substantial reduction of subretinal fluid, second dose was given, and so these patients 4 loading doses and then injection period, so we could go up to 16 weekly dosing straight away after 4 loading doses, and the patient is quite happy with the 20/50 patient. And because this patient is an only eye patient, I'll just keep on having the Q16 injection at the moment. So no safety signal was encountered in this case as well. So another case, this is a treatment-naive PCV patient which was actually enrolled in the Salween study. Left eye already PCV scar and a vision of 320, and this eye 20/40 vision to start with. You can see a baseline, FA and ICJ showing the polypoidal lesions very well. So patient put on faricimab, and you can see after 1 dose, flattening of the PED as well as resolution of subretinal fluid with good maintenance in vision and some improvement in vision later on. So this patient, after 4 loading doses, extended to the Q16 weekly dosing. And at week 16, we performed ICGA. You can see very good complete regression of the polypoidal lesion. So this patient maintained our Q16 weekly dosing, and after 1 year, he was able to be further extended to Q20 weekly dosing, and this is after the 7th injection been given. So very stable disease activity at the moment. 4 loading dose followed by 16 weekly and then Q20 weekly dosing. And again, no safety signal was encountered. So just the key takeaways now. So we have demonstrated why faricimab could be a very good first-line treatment to optimize your patient's outcome. How is this achieved? We can achieve this by having better drying, very good durability, and also by dual inhibitory pathway of both Ang2 and VEGF, so the 3Ds. And how do we know this? Of course, we've got very good clinical trial data to support, as well as our real-world evidence to support these 3Ds in achieving the effects. So with that, thank you very much.
I think let's have another talk, then we'll have combined discussion. You can have a seat here.
Thank you.
So before that, so we have got the panelist also. So I would like to invite the honorable panelist on dais for this session. Dr. Gavin Tan, please. Dr. Vaishali Agarwal, Dr. Bhuvan Channa, Dr. Dinesh Talwar sir, Dr. George, Dr. Anupam, and Dr. Chaitra. So few words about the esteemed panelists. Dr. Gavin Tan, he's currently in Singapore National Eye Center, and he's associate professor and is the head and the senior consultant of surgical retinal department at Singapore National Eye Center. He's also visiting senior consultant for ophthalmology service at KK Women and Children Hospital, providing pediatric retinal service. He's specialist in general ophthalmology and cataract surgery, and a fellow trained in surgical and medical vitreoretinal subspecialty with clinical interest in diabetic retinopathy, ARMD, intraocular tumors, retinal detachments, pediatric retinal disease. He has set up the first ocular plaque brachytherapy service in Singapore in conjunction with the National Cancer Center, Singapore, and is actively involved in the clinical trials at Singapore Eye Research Institute. Dr. Dinesh, I would like to introduce the panelists before we proceed on the. I'll
Sure,
take
no
just
problem.
2 more minutes. Dr. Dinesh Talwar is currently the senior consultant of vitreoretinal services at Center for Sight and Indraprastha Apollo Hospital. He is a very prolific vitreoretinal surgeon of national and international repute, and has been recipient of the prestigious Professor Muhammad Daud Khan Oration of SARC Academy of Ophthalmology and Sadhguru Medal for Outstanding Service, has more than 30 publications in peer-reviewed international journals, and has made more than 150 presentations in various conferences in India and abroad. Dr. George is a senior professor and consultant at vitreoretinal services at Arvind Eye Hospital in Coimbatore. His area of interest is macular diseases, PCV, CSR, AMD, and he has performed more than 8,000 complex VR surgeries and surgical trainer for more than 150 VR fellows. He has more than 100 international publications on PubMed. Okay. Dr. Anupam is currently senior consultant and professor at Malpani Eye Hospital. Dr. Chaitra is the head of vitreoretinal services at Narayan Netralaya, Bengaluru. Dr. Vishal is a senior vitreoretinal surgeon currently at Agarwal Hospital in Jaipur. Dr. Vaishali is an accomplished vitreoretinal surgeon at PGI Chandigarh. Dr. Srinivas Sada is here. Yeah, Srinivas is the Director of Artificial Intelligence and Imaging Research at Doheny Eye Institute and Professor of Ophthalmology at University of California, Los Angeles. So this will be for the next session.
Yeah. So, Arun, can you get one chair for Dr. Srinivas Sada here?
So,
So I think Vishal, you can go ahead. We just heard Dr. Timothy Life telling most of his talk was on clinical trials and all. But what everybody is interested, he did show a couple of cases. But what is the real world experience in nAMD with this faricimab?
Thank you, sir. Thank you, AIOS, APO, and Roche for having me here. So I'll be discussing the Indian real-world experience in nAMD. Although it was only launched early last year, we have a modest data. But whatever we have, I'm going to share with you, and I'll go directly, to the cases because Dr. Timothy has already, discussed the pathophysiology of the drug. These are all my disclosures. So, and the first thing is, why do we need real-world experience, and why is it important? Because as clinicians in our OPD, we do not treat our patients of nAMD or DMD on the basis of the trial criteria. We do not see the lesion size in every patient and decide not to inject or inject, and we do not follow a strict protocol and keep on injecting these patients for the next 2 years. Basically, it's a very heterogeneous population of patients as opposed to RCTs, which is the data is collected in the research settings with a more homogeneous patient population. So, Vabysmo is now approved in 107 countries, and more than 7 million doses have been distributed globally with a very robust safety profile. My experience is of now more than 300 injections since January last year when it was launched in India for nAMD and DME. It has yet not been approved for RVO in India. So coming to the cases, few most severe cases, mainly PCV cases, mostly switch patients. So this 80-year-old gentleman, one-eyed gentleman, had multiple anti-VEGFs, and you can see the fundus photographs on the left side and the serial OCTs on the right side, and this had been injected with multiple anti-VEGFs elsewhere, presented with a fresh bleed with foveal fibrosis. We gave 3 loading doses of Vabysmo here, and you can see the serial OCTs on the right side, and you can see the dramatic resolution of the hemorrhage on the left side. And the last OCT is actually 24 weeks now after the 3rd injection of Vabysmo. The patient has not required a 4th injection till date. The improvement, of course, in the visual acuity was modest because of the fibrosis here. Coming to the second case, again a one-eyed gentleman, aggressive RAP lesion, and you can see the fibrosis and the fresh bleed, treated with aflibercept, multiple aflibercept with us only. And at that time she came in February, and these are the serial OCTs on the right side. You can see the resolution of the fluid and the resolution of the bleed on the left side of the fundus photographs. And the last OCT, and if you compare the last OCT, the 24 weeks post third dose of Vabysmo with the first OCT, you can see the durability and the excellent effect it has on the intraretinal and the subretinal fluid. This was, a particularly, interesting case. She's a, 45-year-old software engineer from Gurgaon, and she was very frustrated because there was multiple recurrences after multiple injections of anti-VEGF, ranibizumab, and brolucizumab elsewhere. Came to us again in February last year and had, this CNVM with RP duplication, and you can see the last OCT in which there is a complete resolution of fluid, and she's maintaining that even after 2 doses of Vabysmo. Coming to PCV cases, a lot of bleed and exudation you see in the left side of the fundus photograph, and actually we were planning to go for a intravitreal TPA and anti-VEGF, but again at that time Vabysmo was launched in India, and we thought that we would try this new drug. And this is the 4 weeks post Vabysmo fundus photograph. You can see the complete resolution of the heme here, and of course the corresponding OCTs and the complete resolution of intraretinal and subretinal fluid, along with the drastic decrease in the bleed. 60-year-old gentleman, multiple PEDs with intraretinal subretinal fluid, again a switch patient, multiple anti-VEGFs were given one-eyed, and this gentleman was given 3 doses, and you can see the serial OCTs on the right side. There is a considerably flattening of the PED, a complete resolution of the intraretinal and the subretinal fluid. The vision is maintaining at 6/9 parts because of the good fovea, and presented with 660 vision, has not required a 4th injection till now, and has been now 20 weeks post 3rd injection of Vabysmo and is in constant follow-up. Again, a young patient, 30-year-old tech engineer from Jaipur, multiple anti-VEGFs given elsewhere, always a subfoveal recurrence, young patient, and this is one of the most dramatic effects of this drug, and it's been now 1 year, and the patient has not required after the loading doses a 4th injection. And if you see the last OCT, and you cannot imagine that this was the first OCT pre-injection, and the patient is actually very happy with 6/6 vision, no metamorphosia and no recurrences. More severe cases, you can see the height of the PED, the amount of bleed here, and multiple PEDs and intraretinal fluid, and presented with the fresh bleed, drop in vision. 3 loading doses were given. So the right side OCTs, the middle OCT is after the 3 doses, 16 weeks post the loading dose, and had a recurrence at 20 weeks, and then we re-injected this patient after 20 weeks of the loading dose, and is stable now. And now we have switched the patient to treat and extend here. Again, you can see the multiple PEDs and the subretinal bleed and hyperreflective area, and multiple anti-VEGFs. Again, a switch patient. 3 loading doses were given. You can see the serial OCTs, and if you see the last OCT and compare it with the first OCT, the PED height has totally flattened. The macula is dry, and the vision is maintaining at 6/12 parts. Again, the patient has not required a 4th injection in these cases. I'm talking of the initial experience of the most severe cases. Of course, not every patient does that well. You can see the octa also, and no vascular reactivation in these patients. So this patient was a vitrectomized patient, had vitrectomy with subretinal TPA for a massive submacular bleed post PCV last year, and again presented after 1 year with a bleed. At that time, you can see the thumb-shaped PED, and we injected the patient with Vabysmo, and you can see the resolution on the left side. The bleed has gone, and if you see the last OCT and compare it with the first OCT, that PED is totally flattened, the fovea is dry, the patient is maintaining 6/9 vision after the loading doses. Again, subretinal hyperreflective material, a lot of bleed here. This was a particularly resistant case. We normally give 3 doses of Vabysmo in our practice. This patient required 4, and the final visual acuity is 6/18. Again, you see the serial OCTs, and the last OCT has no PED, no fluid, and no heme, as observed in the fundus photographs also. And there is no recurrence after the loading doses. The patient is on 20 weeks post-Vabysmo follow-up. So our experience right now is about 318 injections. But many patients are in their first dose, many are in second, some are third. Initially, we tried some PRN dosing also. So, and you can see in PCV patients, almost after 1 month, every patient had a considerably decreased PD height. So almost 50% PD height and central subfield thickness decrease was there in all these patients. But just to collate all the data and to cut the long story short, if you see, this is the data of 50 patients of nAMD in my practice, which have received 3 loading doses and have a follow-up of more than 4 months now. So 85% are on Q12 dosing and more than 66% are on Q16 dosing. So to summarize, in Vabysmo, there is greater numerical gain in vision even after the first injection. And all parameters like intraretinal fluid, subretinal fluid, the bleed as you have seen, the PD height gets improved. And it has a robust safety profile. In my practice, I have not incurred any serious intraocular inflammation cases till now. Still an evolving data, as I said in the beginning, the data sample size is modest, the follow-ups are short, but maybe early next year or later next year, when all these patients will be in their Q12 and Q16 dosing regimen, we'll be able to say confidently about the efficacy. But if my patients of nAMD require 3 or 4 injections in a year after the loading doses, I think this drug will be a game changer. Thank you.
Thank you so much.
Thank you. Thank you, Vishal, showing these 10 cases. So we'll start some honest panel discussion on this. First is, you see this session in a time for change. Has the time for change come, Srinivas? And time for change, because I have time for change means a change from what to what?
Well, I think the title of the session is this a first-line therapy? And I guess the question, the way I like to pose this question is, if it was my mother, what treatment would I choose, right?
Yeah.
Because you have to choose something.
First line.
This is the treatment I would choose first line if it was my mother. Now, obviously, in every country, there are different
Even
issues.
Even for my mother.
You can speak. You can say what you're going to choose for your mother. When I'm running the panel, I'm going to ask that same question to my panelists. But I guess, as I said, there are other factors that might affect decision making, right, with regards to insurance coverage. And we have different issues in the U.S. Every country will have different issues, cost, other factors obviously play a role. But I'm just saying, if everything else is equal and you have to make a choice, what are you going to start with, right? And so that's really the point of this discussion.
The reason I put this question to everybody is that, you see, once we change, we are looking for 2-3 things. One is it a better efficient drying, or is it any wow effect that patient says, doctor, it's a magic drug? Secondly, is the duration increased? And third is about the side effects. There are 3 things we have to ponder about. So maybe one by one we can start from Dinesh. Yeah.
Let's start with Dr. Sada first.
Sada
I mean, what
himself,
was you asked the question, you didn't answer it.
No, I said
because
that
I want three answered. Efficacy.
Yeah,
Means does it offer? You see, first generation anti-VEGF, they still work. They still do drying. What I have felt is the duration is the main factor which gets increased with this. And loading dose is definitely required. It's not that, Vishal, you were saying about the PRN treatment and one injection. Yeah, PRN injection and one dose, whatever is my experience, does not work with faricimab. It has to be a loading dose, definitely.
So this is what I would say. So you're right. First generation agents can work. We know that, right? We all have been using them for a long time. Okay. So there's a few different issues. One is the rapidity of resolution. So we have some data. Again, these are post-hoc analyses, to be fair, but that show that if you're able to get the retina more dry rapidly, that actually translates even a year later to visual outcomes. So that's one. Okay, so in terms, I'm giving my rationale for why I would choose it first line. 2, then you made a very good point about what about safety, right? So we have some real world data now. So, because the trials are never powered to find low frequency safety complications, right? So we have real-world data now. So we know, of course, you can see inflammation with any anti-VEGF, including the first-generation agents. And the real-world data suggests no difference between aflibercept, ranibizumab, and faricimab with regards to inflammation. Obviously, a higher rate with brolucizumab. Okay, so because you might be able to get the same kind of drying with brolucizumab, but then you have to deal with the effect. Then there's going to be a subset of patients that probably, and we're going to get into a discussion in the next panel about where ANG2 probably makes a difference. I don't know, right now we're still studying all the biomarkers, maybe we can predict that. And so I'm just saying that putting that all together, for me, when it comes down to choosing, and I don't have any other barriers, and that's an issue in the US, I will say sometimes we have barriers because we have to go through step therapy for some of our payers, then that's the rationale, that's the logic behind my choice.
Dinesh, your take. Question is specific. Is it your first-line drug today?
Okay, so at this
Firstly,
moment,
yes or no, then
no, at this moment, I differentiate between type 2 CNVMs and type 1 CNVMs. Type 2 CNVMs, I still start with ranibizumab. It's still my first line drug.
above the RP, you
Yes.
start.
Type 2 CNVMs, my drug of choice is between aflibercept and faricimab, with faricimab being my go-to drug if I don't get a response to my first 3 injections of aflibercept.
That means first line never.
The reason is,
First
at
line,
this
yes or
moment,
no?
I think there are
First
two
line,
issues.
yes or no?
Yes, so you have to keep in mind, for us, this is a drug which has just started. I'm very conservative when I
You have
start
to
off with a
depend
new
on- You have
drug.
to depend on experience of all the gentlemen. Also.
Yes, but finally, the reason for real-world data is because you want to rely on what you see. And I want to see what I see before
So we have a diverse here. This gentleman says first line for his mother and my mother also. This gentleman says that he will give a trial for ranibizumab even in type 2 and then if no response.
But
then-
even for your mother?
even for my mother.
Yeah.
In type 1, I would start with aflibercept.
Yeah. George, again, first answer yes or no.
Yeah, first line. Yes, of course. There is no contraindication for it to be first line, except for the cost concern. Currently in India, there is no, it is a first line drug because what makes it first line is same thing what you asked first. Is it efficacious? Second, how is the safety? Safety first. Because, you know.
George, because FDA has approved efficacy, it must be there.
Yes.
Efficacy has to be
No,
there. I
yeah.
don't think so.
And
that
we
any-
have heard from Dr. Timothy
Timothy,
Lai
yeah.
about the efficacy. There's no doubt about it. Now, second comes safety. So that is what makes it first line or second line. Some drugs we use as second line primarily because of that concerns only. So for me, there is no subtype. For example, PCV is a disease so rampant here. No, so in the AMD subset. So where we know that the first line
so
agents.
Let me ask PCV. Let me interrupt you. PCV, you have a aflibercept vis-a-vis faricimab. Your choice. Your choice.
You know,
In a PCV. Treatment naive.
yeah, you know, we give both the options because we have.
Patient will say, doctor, whatever is best you do.
Yeah, then the current best would be Vabysmo.
Coming to one more question is about the drying. Do you get a wow effect in this? Wow effect means patient has a smile after 2-3 weeks, 4 weeks. How much is the amount of drying effect? You see, we all discussed about IOI, SADA said.
So I think the drying effect is better than for first line or the first generation drugs, that's for sure. I think, and it's easier to evaluate drying in switches because those have already failed the first line drug. You will see a dramatic decrease in SRF and sometimes the PEDs as well. And I think in PCVs, the added advantage is you see a lot more polyp closure.
Yeah, Bhuvan,
Yeah,
about the wow effect.
I think, sir, in most of the treatment naive cases, we can get a wow effect, but not as compared to brolucizumab. The action is more slow, so we need a loading dose, but we have a longer duration of action. Maybe
That
after
is
3 or
what
4
I
days.
agree with Bhuvan. I was trying to drive home one fact that you see the amount of effect which comes with one dose, you have to counsel these patients. You have to counsel these patients that, it generally takes time for, this drug to act. This is my personal experience.
Well, that's going to be an
That's what we
interesting.
wanted
it's-
to learn.
Right. So that's not my experience. So my experience, I was just asking Tim and Gavin what they thought. They also see a wow drying effect. And so what I don't know is I can't speak to, I mean, I do have a few Indian patients in my population, in my patient population in the US, but they're relatively a small percentage. What's the interesting thing about this disease is the variation across the globe, right? We don't really study things like that. So I don't know, I can't answer the question whether there's a difference in terms of the rapidity of resolution in Indian patients compared to others. We have to accept that that's possible, but I would say it should be studied. I would say the data from the trial, just like what Tim was saying, and the speaker was saying as well, is the data in the trials is very much was what I'm seeing in practice, that I see a more rapid resolution. We have from the matched phase, we know it's got greater resolution, more rapid compared to aflibercept, right? So, and where we didn't see that difference between 8 milligram and 2 milligram of aflibercept. So that is the same thing that I see in my practice. I see greater drying with this compared to 8 milligram of aflibercept as a whole.
Even
okay?
greater and faster also.
Excuse me?
Greater drying and faster drying.
Yes,
Faster, time to
yes,
dry.
and so as I said, my practice may more resemble the clinical trial. So what I don't know is about the variation from country to
Can I
country.
ask a question?
Chitra, one very important thing he has said, and he has motivated me to ask this. Does your data match with RCTs? Whatever RCTs output they have given, does your data at Narayan Netralaya? I'm going to ask the same question to Dinesh also.
Sir, I just wanted to ask one thing before.
No, you
Do you
must
still use a loading dose even if you see a drying, or you switch to treat and extend after a single injection?
I don't think so. Anybody, with faricimab will immediately after one injection shift to treat and extend. I don't think so.
I think that's been our
Is
experience.
it Timothy, is it okay? But we say that if
It's not
suppose-
preferable. If you can manage to completely dry the retina, definitely, maybe. But then it usually takes 2 or 3 injections. So I mostly do 3 loading instead of 4.
Even after one injection is achieved, right?
If it's dry, the patient is really not willing to inject, then I would closely observe. But I think usually when I initiate
Loading.
therapy,
Loading.
I do tell them
Loading
at
is
least 3 or 4.
Loading is
3 or
4.
4. Based on clinical trial, 4 loading, but clinically, sometimes you can
So
do
Chaitra,
with
the
3.
question is, ball is in your court. Do you have same experience as Sada that he gets similar results as RCTs?
No, not at all. So basically what we've noticed initially was because of the cost of the drug, we were just giving one injection
Forget
and trying
about
to
cost.
wait.
Please don't bring about
No,
this
but
emotional
now
issue of
things
cost.
now things have
Because
changed.
believe me, even in this country, if patients are in effect, patient will pay.
Yeah,
I'm
so
telling you,
who
if
are
my
paying
eye-
and who are taking the injection are taking at least 2 to 3 injections and they're doing well. It has never happened with just one injection because somehow we got to the impression that one injection will last for 6 to 8 weeks. It doesn't work like that. That's why we were initially disappointed with the results.
Mishra, the chairperson.
So I'll say this, what you said is a wow effect is definitely not present in this drug. The wow effect which was seen in brolucizumab is not there. Still, this drug is not yet my first line of treatment. Though I have started brolucizumab as my first line of treatment and I've gone PRN basis right from the beginning itself. I don't give loading doses. And this study which has been published this year in the International Journal about with brolucizumab.
No, we are
No,
talking about
this
this.
I have to give. So we give 3 loading doses, at least 3 to 4 loading doses in faricimab. Safety factor, yes, it's a very safe drug, and brolucizumab, that's always a concern. You have to monitor your patient. So not yet started as first line of treatment, and that effect, what you're saying, is usually seen only after the 3rd loading doses.
I think it's important to mention here what's happening really. There's a difference in the perception which is coming because I think you're already giving 3, Dr. Sada, you're already giving 3 loading doses. So when you're giving the 3 loading doses, you get straight to the durability point. But when you give the first injection, and if you like what you saw was going on in India first, that you're just watching how long it works, and it doesn't work that long. So what happens is whatever little wow you're getting gets lost when you get the recurrence. The durability comes when you give prolonged doses. It does not come from a single
I think
dose
that is
or
so-
even 2 doses. The durability comes when you give give the first 2-3 doses at monthly intervals and then slowly extend. What basically a wrong perception came from the Tenaya and Lucerne that after your 3 doses, you just go to 12 weeks or 16 weeks. That doesn't work. You have to go slowly, extend. You extend from 4 to 6 to 8 to 12, and you get very good results. The important thing is, I actually believe this is like a tortoise that wins the race in the long term rather than the rabbit which just sprints away. It doesn't. And that's the important thing here.
Okay, Dinesh.
What is your view?
Anupam.
Okay.
Anupam, RCT versus real world. Faricimab. Your experience.
My experience in treatment naive is not too much. I have basically used in switch patients, and there, of course, it is very good.
Do you agree with this theory, what he is saying, tortoise versus rabbit?
Yeah, it's slow to work, but
maybe brolucizumab is a rabbit and this is a tortoise.
yeah.
No, this. If I can add to that.
Another last question which you gentlemen should be prepared is that you see, is there some difference between your experience and our experiences? So, like here you say wow effect, they say no wow effect. You say rabbit and they say tortoise.
Yeah, so it does seem like some of the comments, as I said, it's not my experience. Of course, there is variability across patients, right? I mean, there are patients where after one injection they're completely dry, and there are some patients who have residual fluid and you have to keep going. So I'm sure I have patients who don't have a quote-unquote wow effect by your definition, but I'm talking about on average, okay? So well, in terms of my practice, to actually answer Dr. Dinesh's question, again, the trials were done in a certain way, and there's a trial protocol, and if you're going to get the trial results, ideally you adhere to that. But the practicality is most of us don't do things in practice exactly like the trials. And so I do exactly what Tim does. So I treat to dry, and sometimes it does take 3 injections. Maybe it takes more for a few patients, right? And in which case that I keep going. The others I don't. I don't know, that could be a mistake, because we do think that there could be a disease-modifying effect from faricimab, right? I'm waiting to see, there's going to be AO data soon about seeing visualizing the pericytes and seeing, how they come back and things of that sort. That could modify my thinking. I might do loading even with the dry retina if I start to see that. But for now, this is what I do. But I don't know if we're losing a disease-modifying effect by not giving persistent treatment in the face of a dry retina. That's a question. Ideally, I'd like to see a randomized trial comparing those 2 strategies.
Yeah, Vishal, you wanted to say something.
So just one very quick comment. Sir, we are using brolucizumab, we are using aflibercept. All drugs are good and have a robust safety profile, except maybe brolucizumab, which has a higher incidence of IOI. And most of these drugs give you a Q12 dosing after the loading dose. We all know that. So the test is whether this drug can give you in more than, of course, not in 100%, but in more than 50% patients are your patients on nAMD on Q16 dosing.
Claim is that only.
So what I have presented is a very small data. Maybe in the next year we will get more data, and if more than 50% require Q16 dosing, then I think it is more superior to the other drugs.
But Timothy showed actually that the real life data, the average was at 8 weeks rather than 12 weeks.
Yeah, correct.
So I was a little surprised
That's not
because
true.
You said that.
all the
You said
studies
that.
which were shown went to 8 weeks, 70 to 80%, whereas the trial data was 70 to 80% at 12 weeks or more. So
That's more than 8 weeks,
I
but
think,
that's a minority of patients actually. Majority of patients could be on 12 weekly or more, so over 50%.
Sometimes this less wow effect is also good, especially when you're dealing with a large vascularized serous PEDs and all. You don't need that, concern about RIP. You don't want that, when you have this wow effect with brolucizumab, that is where this one injection and extension comes in, where you don't want to load. Where you don't want a wow effect, I think the best way to go is like slow improvement, and which is durable rather than.
I have one question to Dr.
Lalit,
Sardar.
for me, a game changer could be if you find that the fibrosis following the resolution of a type 2 CNVM with faricimab is less. That could make faricimab my first line treatment for type 2 CNVMs, and that's what I'd like to ask
100%.
Timothy, whether he's seen such a change in the amount of fibrosis that occurs with the healing of these CNVMs.
I agree 100% that fibrosis is one issue, but the thing is we recently have had this experience for last 1 year only. Fibrosis is a slow process and it may take time for us to evaluate whether it's occurring or not. So Timothy, you have more experience in fibrosis. RCTs are different. In your practical world, is fibrosis less?
I would say we don't get a lot of fibrosis, to be honest, because patients presented early. So those patients, if they presented with a large hemorrhage, no matter which drug you use, you will still get a lot of fibrosis.
Okay, I think we have to close this session now because the second session will start. But I thank all the panelists for a very exciting discussion, very honest opinions being said here. And I agree, time for us to change, yes. But how to change, I think all of us keep learning from each other. With this, I thank all the speakers and panelists. Thank you so much.
Thank you, sir. Now we have the next session on DME. May I call upon Dr. Vaishali Gupta to chair the next session. Dr. Vaishali Gupta is an accomplished vitreoretinal and UV expert of international repute. She is currently working as the Chief of Retina and UV Expert at PGI Chandigarh. Ma'am, please come. She has more than 281 publications. Ma'am, kindly take over.
So, in the meantime, while a beautiful photograph is being clicked, so I would like to begin the session 2, which is on diabetic macular edema. There is one more photograph, Tim. So beginning with the diabetic macular edema, we all do understand that managing diabetic macular edema is tougher than AMD. And with this, I would like to invite my moderator, Dr. Srinivas Sada from this, who doesn't need any introduction. And without wasting much time, we go on to Dr. Kevin Tan from Singapore, who is going to speak on time for change, integrating faricimab into first-line therapy for DME. So I think we are following the same pattern, that is it going to be first-line for DME or not? Over to you, Gavin.
Thank you very much for the kind introduction. These are the disclaimers. And let's review again the landscape so far. Tim has done a lot of the hard work for me. We know anti-VEGFs have redefined patient care, same as for AMD. It's changed the way we've treated DME. But there are certain limitations, same limitations: frequent injections, patient and caregiver burden, missed visits, suboptimal long-term outcomes. And they don't really address the multifactorial nature of DME. We know DME is a very complicated disease. Faricimab, again, is bispecific, so it doesn't just block VEGF, it also blocks angiopoietin 2. And there's a large program that has evaluated it in various diseases. Let's quickly go into this. Yes, so faricimab is supported by another large real-world data program of more than 150,000 patients that have really proven the good safety profile. So let's go to dive a little bit deeper into the dual inhibition for diabetic macular edema. Tim showed this earlier, where we know increasing angiopoietin 2 drives vascular instability in pathological tissue. And we know in diabetic macular edema in particular, there are many biomarkers that have provided very good evidence for the benefits of the dual inhibition pathway compared to VEGF blockade alone. And when you're looking at the effects of elevated VEGF and elevated ANG2, I think you look on the left, we do know neovascularization and vascular leakage is an important part. And we do know, and I will demonstrate later, there is good evidence reduction of fluid is faster in DME with the dual inhibition blockade. We also see greater resolution of the macular leakage and reduction of hard exudates. We also know it affects inflammation, hyperreflexive foci, a good surrogate on OCT for inflammatory cells in the retina. And I will later demonstrate how, when you look at this biomarker, again, blocking angiopoietin 2 together with VEGF is effective. And lastly, there's some evidence in DME where fibrosis is also protected or prevented with the reduction of development of epiretinal membranes. So again, going back to the clinical trial, you need to understand what they did here in order to apply it to our studies. It was center-involved DME more than subfield thickness 325, And again, the range of best corrected visual acuity was 25 to 73. The treatment pathology was very similar to what we do in the real world. We extended the duration between injections after the loading dose if it was stable. We reduced, obviously, if it was worsening, and they looked at both the anatomical OCT and best corrected visual acuity. And if there was neither the extension or reduction criteria, you maintained the dosing interval. So in other words, if it was improving, you kept injecting until you got a dry retina. So let's look at what happens to the reduction of macular leakage. Again, in a clinical trial, you have fluorescein angiogram for most patients, almost all. Great advantage about what we do in the clinic. And as you can see here, at week 16, so it's after 4 loading doses in both arms, you're going to make sure it's equal. And there was a very big difference, almost a double, in terms of the median macular leakage difference between aflibercept and faricimab. As you can see, there's a lot less leakage here, 53% less with faricimab compared to aflibercept. And if you want to look back at what happens if you had increased the dose of aflibercept instead, we see data from the PHOTON trial did not seem to suggest a similar difference. Next, we look at the hyperreflective foci. Again, these small hyperreflective dots that you can see on the OCT. And again, they use a size in order to differentiate them from hard exudates. And you can see again, consistently throughout the clinical trial, there are less hyperreflective foci and less hyperreflective foci volume observed in the faricimab arms. And this is both arms compared to the aflibercept arm. If we look at hard exudates, again, hard exudates were segmented from the OCTs, and there was a reflectivity and a size definition. When looking at the hard exudates volume as well as the count in the central 3 millimeters, this is what we usually expect. There's an initial increase as you get drying, and in the long term, it reduces in time. And again, both looking at volume and count, you have that consistent signal where in both faricimab arms, it was less than the aflibercept arm. And that last thing that I mentioned earlier about reducing fibrosis in diabetic macular edema, we know that in a lot of diabetic macular patients, with time, you will get a epiretinal membrane or a vitreomacular interface proliferation. And in the Yosemite and Ryan trial, they did look at the occurrence of this in all 3 arms. And as you can see there, again, the faricimab arm had less risk of formation of ERM at the end of 100 weeks here. And again, it seems to have a dose-dependent relationship where the 8-weekly dose that had more frequent injections had the lowest percentage. So the take-home message in this first part is that faricimab is a bispecific antibody. It targets both pathways, and the clinical biomarkers show potential in drying anatomical benefits of dual inhibition compared to VEGF inhibition alone. Next, we're going to look at a little bit into the details of the data that demonstrates better disease control. Here, we're really looking at the head-to-head CST reductions over time in all 3 arms. And so you can see there is a greater reduction both at the standardized time point of 16 weeks as well as overall the course of the entire clinical trial. And if you look at similar data where the approach is trying to increase the dosage or the molar concentration of the drug delivered, we already know the old data from the READ-3 study that did not demonstrate that quadrupling the dose of ranibizumab increased the drying effect compared to 0.5 milligrams. And as mentioned earlier, that's similar in the PHOTON study, where a 4 times dose of aflibercept did not appear to provide an anatomical advantage. If you look at how you would want to compare these data, again, we would love for somebody to organize a nicely designed randomized control trial that compares these 2 newer drugs that we have, 8 milligram and faricimab, but we don't. So as mentioned by Tim earlier, you can use a matching adjusted network meta-analysis where by comparing the features of the clinical trial patients, you can try to approximate what would have happened if you compared these patients head to head. And what they did find was that for best corrected visual acuity, again, you did not see a statistically significant difference, although it trended to favor faricimab. But in the anatomical effect, you did see there was a convincing difference between faricimab and aflibercept, which favored faricimab having a better drying effect. And if you looked at the fluid fluctuations over time, it also demonstrated that there was greater fluid fluctuations in the patients that were treated in the 16-weekly group. You can see over here, that's the dark blue triangles, compared with 2 milligrams. So you are getting more and more fluctuations when you go to 16 weeks, even when you quadruple the dose. And that fluctuations is not as pronounced in the Yosemite and Rhine study. If you look at how fast you achieve first drying, defined by the absence of IRF, intraretinal fluid, again, you're seeing that time point is met in the faricimab arms much earlier than in the aflibercept arms. And it was between 7 to 9 injections in the faricimab arms and a much later time point of 13 injections in the aflibercept 2 milligram arm. So retinal drying, we know, is very important for visual outcomes. And obviously, we have seen the linkage between the drying effect and visual outcomes in DME. It doesn't correlate one-to-one, and we know central subfield thickness is not the best biomarker, but increasingly by looking at a combination of total retinal volume, fluid volume, intraretinal fluid volume, and subretinal fluid volume, you have a good correlation with visual outcomes at 12 months in various studies. If you look at the real-world data, this is the Far Retina Iris Registry from America. It does also demonstrate that the improvement in the mean CST in both treatment, naive, and previously treated eyes with DME was impressive or effective. So the take-home message in this portion is you get greater drying in the head-to-head period. And the dual inhibition leads to robust drying effect over 2 years, and that drying effect is demonstrated again in the real-world clinical studies. The last thing I would like to cover in this talk is the durability. And again, can faricimab reduce treatment burden for our DME patients? So we have additional data here where we are looking at the RONEX study, which is an extension study of the Yosemite and Rhine, where patients were then allowed to switch over to faricimab in all arms on a treat and extend dosing regimen. And this went up to 4 years, so you get greater amount of data. We can see here in all arms, even at 4 years, you maintained a very, very good visual acuity, as well as a very dry retina in both graphs, visual acuity on top and central subfield thickness below. Again, when you look at the absence of DME, at the end of the RONEX study, that was even better than at the end of the Yosemite and Rhine study, where you achieve more than 95% having a dry retina compared with 80% at the end of Yosemite and Rhine. So whatever benefits you're getting from treating continues to extend out in years 3 and years 4. And if you looked at the dosing intervals, at the end of 4 years, all 3 arms which had been switched to faricimab treat and extend were able to achieve more than 75% Q12 weekly or longer, and more than 60% Q16 weekly or longer intervals. We also see again, even in the patients which were switched over from this aflibercept group, you had a drying effect and they continued to improve, eventually achieving an overall percentage of absence of fluid or absence of diabetic macular edema that was quite equal between all 3 arms. And again, we saw earlier that difference, 6 to 9 injections with the original faricimab groups, taking up to 15 injections to have 90 percentile dry retina in the aflibercept group, and that improved when you switch them over, achieving that similar 96-97% dry retina after an additional 50 weeks. And lastly, looking at the safety profile, we see that the safety profile, as you extend up to 4 years of treatment for faricimab, was very, very good and quite similar to all the real-world data that we've seen prior. We also know that the real-world data, and again, this is far retina, far wide, which look at UK and US patients. You can see, again, this is real-world treatment. They didn't follow a clinical trial protocol. As expected, in the first 6 months, you had more injections, a mean of 3.4 in the American data and a mean of 4.4 in the UK data, and this dropped quite dramatically to 1.9 and 1.7 respectively in the second 6 months of treatment. So you could see that you could rapidly extend these patients. And on average, they receive only 2 injections on the second 6 months or less. So to revise and recap all of this, again, we see drying and durability are linked. We see clinical trial data that demonstrates the extended durability of faricimab and continuing to improve at 4 years. And again, the durability outcomes we see in the real-world studies do reflect or replicate the results in clinical trials. I'm going to go through lastly a few cases in my own experience of DME, and I've chosen to show some treatment-naive cases. The first patient was a 59-year-old Indian lady, a preschool teacher, had job demands, didn't really want to come back very often for injection, had diabetic macular edema in her right eye. We started with a loading injection, as you can see, and you get that dramatic improvement, that wow factor, if you want to say, after 1 injection, and it continues to improve. This was one of the earlier patients, so although we saw a dry retina, we didn't want to extend them early. We wanted to see whether completing the loading dose would give us better disease-modifying effect. And with time, we could rapidly extend the patients out. We saw improvement of the diabetic retinopathy as well to mild non-proliferative retinopathy. And in this case, we had an FFA that was also done, and it showed really a dry retina after 4 injections. And if you compare the FFA before and after the 4 injections, you see it's a very, very nice demonstration of what my earlier biomarker presentation covered, reduction of macular leakage. And that was that data, again, recapping. In the clinical trial, you see the median area of macular leakage at the end of 16 weeks was 53% lower with faricimab compared to aflibercept. The second case that I have may represent some of the cases I know that you get in India, which are very much more challenging, late presentation, poor vision, extremely swollen maculas. In this case, it was bilateral. You see a ton of fluid, it's subretinal fluid, intraretinal fluid, hyperreflective foci, lots of heart exudates. This patient had the works, a young Chinese male. This is the treatment pathology in the right eye, where we again loaded 3 injections. Unfortunately, the patient kind of refused the 4th loading injection here, and then received further injections after that. And you can see there was an improvement. I would say not immediate. Again, this was a very severe case. But even after 2 injections, you had pretty much a dry fovea center, and a lot of the peripheral fluid improved with time. And in this eye, we could eventually extend the patient out to a much longer duration. He had cataract surgery in between as well. And we eventually got him up to 16 weeks, again, with a much improved severity of the diabetic retinopathy, a dry retina, and vision that had been restored to 20/30. We saw similar findings in the other eye. Remember, the right eye was dramatic. He was counting fingers at the start. He ended up 20/30. We did do cataract surgery in between. This other eye was 2100, 580 microns subfield thickness. After just 2 injections, we see significant improvement. He dried out after 4 injections, and obviously there was a little bit of an aggressive extension here where you saw some recurrence. And we went back to the old treatment interval where we got the retina stabilized and then extended again. And eventually being able to go out to at least a 16-week interval or longer in this patient. So to summarize this patient's findings, he ended up with good vision, 20/30 in both eyes. His central retinal thickness improved from 900 to 300 and 600 to 200 respectively. And you can see you had reduction of intraretinal fluid, subretinal fluid, reduction of hyperreflective foci, as well as reduction of the heart exudates in this patient's eyes bilaterally. And again, it's similar in terms of what you found in the clinical trials where you have that biomarker reducing over time. So in conclusion, faricimab provides dual inhibition of both VEGF and angiopoietin-2, and that will address in our diabetic macular edema patients not just the vascular leakage, although it does that better, but inflammation, neovascularization, and fibrosis as well. It offers rapid anatomical control and better drying effect, as you can see, both in the clinical trial data, the real-world data, and in my case that I presented. You can get extended treatment intervals that results in less frequent dosing, and there are similar outcomes in efficacy and safety in the real world with the clinical trials. And with that, I thank you, and we can go on to the next speaker.
Thank you. Thank you, Gavin, for very convincingly showing us the drying and durability, 2 Ds we need in diabetic macular edema. So before we move on to our next talk on the real world experience, I would like to invite our eminent panel representing the best of the country, Dr. Vinod Agarwal from AIMS New Delhi, to please join us. Dr. Alai Majumdar from Lucknow, Dr. Anirudh Methi from Kolkata, Dr. Praveen Sen from Chandigarh, and Dr. Ali Bankar from Ahmedabad. Please join us. And it is indeed my privilege to invite Dr. Debdulal Chakrabarti, who is coming from a very high volume center in India, Disha Eye Hospital from Kolkata. And he is going to share the real life experience of using faricimab in Indian population in diabetic macular edema. Over to you, Dr. Chakrabarti.
Would like to thank the organizers and thank you, ma'am, for inviting me. So we'll be sharing some real-world experience in DME. The slides don't seem to be moving. Just a moment. Yeah, okay. So basically, this is a very small study, India's first real-world assessment of faricimab in diabetic macular edema. It's called the Clinical Evaluation of Faricimab in Real-World Diabetic Macular Edema in India, a multi-center observational study. And this was to evaluate efficacy of faricimab in real-world clinical settings in India for treating diabetic macular edema in treatment-naive and recalcitrant eyes. So this was basically analysis of data from 4 hospitals, Disha Eye hospitals, and also Netralayam Super Speciality, Global Eye Hospitals, and Shankar Lal Sangvi Eye Institute in Mumbai. So this was a total of 39 patients with a mean of 57 years, 16 being treatment naive and 23 recalcitrant patients. And these were dosed with the initial loading of 3 doses, not 4 as in the label. And we followed usual standard retreatment criteria. So the primary objective was to see what was the change in visual acuity, and the secondary objectives were to evaluate change in CMT and in IRF, SRF, and also try and look at HRF, hyperreflective foci, in inner and outer retinal regions from baseline to week 24. So moving on straight to the results, faricimab led to robust visual gains in both treatment naive and recalcitrant group. This is the naive group, and as you can see, after 3 loading doses, there was a really significant improvement in vision. And this was also noted in the recalcitrant group, although to a lesser extent, as has already been discussed regarding any anti-VEGF. This I believe is true. And as we moved on to the PRN phase, there's a slight decrease in the visual acuity, which is only to be expected. Now, if you look at the proportion of patients gaining more than 10 and more than 15 letters in treatment naive and recalcitrant groups, you have 62% patients gaining more than 10 letters in the treatment naive group and 56% in the recalcitrant group, and more than 15 letters was 37% versus 43%. So with the CMT, the central macular thickness, with the initial 3 injections, there was really good improvement, and this more or less persisted with the PRN phase also. So this was really heartening. And if you look at the intraretinal fluid status, 81% of naive and 91% of recalcitrant patients had IRF And by 3 months, this was really reduced to actually 0% in the naive group and 8.7% in the recalcitrant group. With SRF, it was 75% and 87% in the two groups, and reduced to 0% after 3 injections loading doses. And then again, there was some increase in the PRN phase. So we tried looking at hyperreflective foci. This was manually done with 8 OCT is being evaluated, and so this is something we noted, that in the outer retina there was a significant reduction with HRF over time, and both in the naive and the recalcitrant groups, and also in the inner retina. We would probably do better with using rasters and doing some AI interpretation of the HRF, which we plan to do subsequently. So the key insights are, overall 80% of the patients were able to achieve an extension of 12-weekly dosing, and the mean number of injections in the maintenance phase in treatment naive group was 1.87 and 1.78 in the recalcitrant group. Now, we didn't have any safety signals in this small study. So the key takeaways were clear DME. This study is one of the first to be published from India regarding faricimab and DME. Both treatment naive and recalcitrant groups exhibited significant improvements in visual acuity and reduction in CMT over 6 months. Both IRF and SRF resolved significantly, and there was reduction in hyperreflective foci, which actually could be an indication that there was some amount of reduction of inflammation with faricimab. No ocular or systemic adverse events, as I mentioned, and these are consistent with the Yosemite and Rhine trials, the results that we had. And probably here, the dual inhibition of ANG2 and VEGF-A with faricimab as first-line treatment has the potential to optimize treatment outcomes in DME. Before I finish off, I'll like to show a few cases. So this is the first case, really bad-looking retina with a lot of hemorrhages and exudates and stuff. So you can see, the OCT doesn't look too, good, and we. One thing here is we actually go for 3 loading doses as opposed to the labeled 4 doses. So this is how things changed. After the first, we injected the second. This is after the second, and after the third, this was the scenario. So there was a speck of intraretinal fluid here, and we held up, and this is 1 month after the third injection. So we again waited. We went with monthly, evaluations of these patients, and this is after 4th month of the third injection. So the OCT looks good. The vision is also good. And this is, at that point in time. And, actually, if you notice here, this is 13/8/2024. So this is basically 5 months later, you have increase in intraretinal fluid, and we inject the next Vabysmo. And this is exactly after a month or so. And this is actually, again, after 5 months, we had a recurrence. So we again injected, and this is after a month of the last injection. So, you really have retina that looks really nice as compared to the first one. And this is the next patient. You can see, again, intraretinal and subretinal fluid, some exudates here. And we injected the first Vabysmo retina. The OCT started looking better. The SRF was gone. There was intraretinal fluid that was still persisting. So we injected the second injection. Retina looked a little better compared to the second one. So the OCT, you can see still some IRF here. We injected the third one, and this is how the retina looked. Again, nice and neat, and really looks like a, normal eye for that matter. And this is actually 6 months after the third injection. Patient hasn't had any more injections. So actually you can, in some cases, maybe you can just be lucky, or the patient's diabetic status, if it is good, then maybe the patient can be lucky. So this is a patient who happens to be, post PRP with diabetic macular edema after 3 ranibizumab and 2 aflibercept injections. So you can see the laser marks here. And the patient at that point in time had subretinal fluid and significant intraretinal fluid. And we actually offered Vabysmo. We always do 3 loading doses for recalcitrant ones also. And this is how the patient improved over time. And with the third injection, actually the patient, you can see, actually had really good OCTs here, some improvement in the vision as well, and the retina looks good. Maybe there's some regression of the DR as well. So this is 3 months post the third injection, and you can see some fluid coming back, and this is definitely the time to re-inject. So thank you for your kind attention.
Thank you. Over to Vas.
Thank you, Vaishali. Hopefully this is on. So we're going to move to our discussion. We have negative 20 minutes for our discussion because we're pretty far behind. So we'll try to keep it short, but I would like to get some thoughts from all of the panelists. I only have time for a few of the questions I had wanted to pose. So maybe what I'll do is we'll start from Dr. Devdalal, and we'll work this way, and then we'll go this way with this, just hopefully 1 to 2 word answers to this question. So I just want to first start, because the theme of this session is, what are we using as our first-line therapy, and do we have good evidence to change to our first-line therapy? So I want to know, Dr. Devdalal, what is your first-line therapy for DME? And then for each of the panelists, just try to give a one-word answer.
Faricimab, if the patient agrees.
So but let's give.
Could be a biosimilar ranibizumab or Eylea.
Okay, next.
If the affordability is not a problem, faricimab.
Yeah, I think I would agree to the same. If affordability is not a problem, faricimab would be my first line, and it's because of the disease-modifying effect of faricimab.
I agree, but affordability is a big issue, I think, over here. Second major thing is, I think what we need to understand is, it is not what happens immediately after 3-4 injections. What happens over next year, next 3-4 years, that is important. And I think if we can have significant change in the interval of the injection, that would be a big gain, which we are yet to see.
Go ahead.
Yeah, I have a little different approach. If my central macular thickness is more than 500 microns, yes, faricimab as first line. And affordability is a choice. I give my patients a choice. But if it's below 500 microns, and probably a biosimilar or a ranibizumab. But yes, above 500 microns, faricimab will be the first line. Thank you.
Yeah, I'm similar. If there's no cost option, I think faricimab is my first line.
Yep, same. No cost issue, faricimab.
Okay, so actually, so everyone gave more than, except for maybe Dr. Devdalal, more than a one-word answer, but that's okay, because you actually addressed my second question, which was going to be, if you're not using faricimab first line, what is the reason? I did want to, so I don't have to ask that one now, so since you guys did such a good job with that. I did want to ask, though, about, somebody had mentioned about the disease modification, and I just was curious, how does that impact, maybe this one I'll throw out to any of the panelists since everyone's had a chance to speak, how does the disease modification aspect that we talk about with faricimab, how does that impact your thought process? Because cost has been mentioned, but by disease modification, we're saying that long term we may need less treatment for patients. So the cost may actually even out. So how does that, anybody want to weigh in on that?
May I?
Let Dr. Parveen go, and then, yeah. Dr. Parveen.
So I would say here in diabetes, in diabetic macular edema, probably faricimab has an edge over the other simple anti-VEGF, because we know there are almost 30% of patients of DME which do not respond to just an anti-VEGF injection, because there are parallel so many other changes which are also responsible for DME. And if we have a molecule which at least affects one more, I'd be happy to use it. Number two, I think as you read the pathology of ANG2 pathway, it does mention increased pericyte recruitment. Now the basis of DME is that we have loss of pericytes and we have outpouching and causing microaneurysm formation. And if we could reverse it by increased pericyte recruitment, decrease in MAs, which some of the slides showed that macular leakage comes down. If you see them, the number of MAs are coming down. And as you mentioned that if you're probably looking at pericyte recruitment in vitro models with faricimab, then probably this could be one of the reasons why we are having a better disease modifying effect.
Okay. Dr. Loh, you wanted to make a comment. Thanks.
I was saying, let's go back in years. After ranibizumab, why did we extend the research into anti-VEGFs. Two reasons. We wanted a more efficacious molecule, and number two, we wanted to extend the durability. In DME, as we know, two major factors are working. VEGF is one factor and inflammation is the other factor. Now, this is one molecule that is targeting both the pathways of disease in diabetic macular edema. And this is probably the only molecule that is acting on both these pathways and cutting it down. Thus, the both intentions of the research progression in this sphere were addressed. The duration was increased, inter-injection duration. And number two, the efficacy was increased because two synergistic pathways were being cut down, thus increasing efficacy and duration as well. So faricimab, that's why not only modifies the disease pattern, it modifies the disease pathology, reduces the biomarkers, and thus improves the outcome of the disease, both structurally and functionally. So the functionality is important. We are all in vision business. Let's be blunt. Vision matters. So it is not just the structural improvement, that also the functional improvement of the patient that actually pushes faricimab above all the other molecules.
Thanks, Dr. I don't know if you looked at my questions already, because you answered like 3 or 4 of them that I was going to ask about the. And I'm curious to actually let me make Tim make his comment first. But I was going to ask the panel, and maybe if Shelley will shut me down after that, about your thoughts about the relevance of ANG2. But go ahead.
It's shown by Gavin's data and also the other study on the Peloton Camino. The FA is very important. So if you look at the match phase data, faricimab can reduce the leakage much better than aflibercept 2 milligrams. So I think that's very convincing, as shown by Gavin's data.
I think the leakage data is really amazing. So yeah, go ahead, Gavin.
So for me, I think the other upside is the inflammation. And again, you would have a little bit of doubt how effective it really is, but I think the hyperreflective foci is quite convincing. And we have tried to look at how our recalcitrance patients did when previously we would switch a lot of them to Ozurdex, for example, compared to our recent pathology where we're switching those patients to faricimab. And we found that, again, it's not matched, it's retrospective. There were 2 different time periods. Both visual and anatomical data suggested that faricimab did better, which was surprising to me because I expected a visual difference, but even the anatomical was fairly convincing.
Alay, you looked like you wanted to make a comment. And then, Vishal, I'll leave it to you to say when we should close, because we're already 5 minutes over. So we have to. So maybe Alay gets the last comment then, is that right? Okay.
Yeah, I was just going to mention about its comparison with Ozurdex, particularly in chronic DMEs and DMEs where there is a diffuse macular edema, a lot of hyperrefractive foci. And there was a lot of talk that probably Ozurdex is a better option than the first generation anti-VEGFs. And I think with the faricimab use, what I've seen in my clinical practice, I think it has a better effect than Ozurdex and also a longer lasting effect than Ozurdex. We all know Ozurdex effect, though it's claimed. I think in these patients, it's usually around 8 to 9 weeks. That's a max with an Ozurdex. But with faricimab, I think we are able to get a longer duration of action.
Yeah, I think I would agree with Dr. Alay also. For me also in my real world and my patients, I use hard exudates as a biomarker that this definitely needs to go to faricimab as a first line, because here, they do much better. And I think if you look again, hard exudates are usually because there are leaky microorganisms present, cercinate of MA is present. So I think it's doing something there.
Okay, Dr. Aniruddha, we're going to give you the last word, because I see Vishali is really looking at me to stop. So you get the last word.
We have seen this Ronex extension trial, like end of 4 years, almost more than 90% is not having DME at all. So we have been using this molecule for maybe less than a year, or rather a year. Just the question to you, like it's there in US for last 3-4 years. So how many of your patient actually is following this clinical trial data? Do you get majority of the patients who are not needing any injections after 3 years of treatment or so?
Yeah, Vishal, looks like I get the last word on the panel then. So thank you for the question. So yes, I would say that overall my experience mirrors the trials. I mean, obviously there's going to be patients who don't respond as well and patients who respond really
Very well.
super. I do see a diminishing need for treatment over time. I would add that it's not just our clinical experience now that's extending into multiple years. We do have patients in the original trials. I don't know if it was Gavin or Tim who mentioned that because of Ronex, we have 4 years of data now, even in the trial patients, and so that's the kind of thing that we're seeing. And the interesting discussions are about stopping therapy, right? So because you extend, and then we do stop in most of our DME subjects, and they seem to have some long-term stabilization. That's why I've started to really come on board the disease-modifying train. So, okay, Vishali, I'll turn it back to you then.
Thank you, Vas. And with this, I think we have to conclude because the next session people are standing at the back. Thank you, Roche, for the opportunity. And as far as the summary of DME is concerned, I think the panel and the experts agree that it's relatively safe. We have better duration, we have disease modifying, we have less fluctuations, and we have better drying. This is something we all look for, and probably I think this is time for change if you already haven't changed. And the last word would be by Sir about AMD, and then we conclude.
So we have seen the dual effect of this bispecific antibody on ANG-A and ANG2 and VEGF-A. That helps in reduction in the inflammation part, the reduction in the neovascularization part, and also achieves vascular stability. So we have discussed it all that yes, near future we do see this drug as coming as a first line treatment, especially because of its very good high safety profile. So we'll have more data coming out of our studies, and we'll follow it up. Thank you so much for attending this. Thank you, Roche. Thank you so much.
Yeah, thank you.